those are the neuromuscular imbalances. What is the good news? They're modifiable. So all four of those neuromuscular imbalances I talk about can be modified with rigorous targeted neuromuscular training.
All right, let's get going. So, Tim, welcome to the podcast.
Thank you, Erica. Appreciate the invite.
I'm really happy you're here today to talk about everything ACL, risk factors, rehab, timelines, or maybe we shouldn't go by timelines with rehab. So, we got a lot to talk about today. But before we get into that, maybe just remind the listeners of all of your amazing work in this space and all the research you've done and kind of what you're up to today.
Yeah, so I mean, I'll just flash out for you my book here. It's all laid out here in my book, and understanding and preventing non-contact ACL injuries. I wish I wouldn't have called it preventing. It should be reducing risk of, because prevention implies that you can make a specific episode, you can stop it from happening. That we can't do. What we can do is reduce the risk in a population to a lower level, significantly lower level. We've demonstrated that repeatedly in both our original work and in multiple meta-analyses. You can reduce the risk of all ACL injuries with targeted neuromuscular training by half, and in female athletes, girls and women, by two-thirds with targeted neuromuscular training that directly addresses the mechanism. I've studied this problem. Oh, it's amazing. I hate to date myself, but 33 years I've been on this problem. And our group was the first to publish data. This was actually in soccer. This was at Soccer World, which is north side of Cincinnati, where I grew up and where I started working in this field. We had uh, athletic trainers at all the fields. So to determine risk, it's difficult, but relatively easier to measure the numerator, which is how many injuries that you have. The difficult part is the denominator. You have to do that by rate, which is how much exposure that athlete has. And as any coach or trainer knows, that's difficult to do. Well, we had athletic trainers on site, and the hypothesis we were testing was at that time, which was the early 90s, our surgeons thought that on that old plastic astroturf, that ACLs happen more on turf than they do on grass. That was the hypothesis. Now we tested that out, and we had hour-long games, so the matches were co-ed, and they were limited to an hour. Whoever was winning it at an hour, that was done. And also, it was co-ed, so of course the guys, they only recruited, it had to be half women, so they always recruited exactly half women to play with the guys. And we measured we knew the exact number of minutes everybody played. And when we looked at the data in the old AstroTurf, we didn't find a difference between plastic AstroTurf and grass. That's not true today. The new rubberized turfs, the NFL team docs showed it's actually 62% higher risk of an ACL on the rubberized turfs than natural grass. But the old plastic AstroTurf was not different. So we had done years worth of work and thought, well, this is a bust, and started looking at the data. And something that really slapped us in the face was that women and girls were 6.2 times more likely to rupture their ACL than boys and men. And that's what started this cascade of research back, it's like I said, 33 years ago now. And so we've spent over the last 3 decades trying to figure out why that is. And if you're going to be able to reduce the risk of an injury, a chaotic injury like an ACL injury, everything we do is mechanism based, whether it's a disease or an injury. That's the way I was trained. That's the way we do all of our work. It's got to be mechanism based. If it's not based on the mechanism, it's not going to work. So here is how you tear your ACL. So basically, this is my tibia, my shin bone. This is my femur, my quad bone. And this is my fibula, which is the lateral side of the knee joint. So what happens is you get some kind of perturbation. The defender moves a certain way and you react to it, or the offensive player makes a dribble and the defender reacts, which is more often the way it occurs. And the trunk becomes out of control. The trunk moves over the lateral side of the knee joint, and with it, the center of mass. Well, in response to that, what happens is the knee and the hip collapse inward, the tibia collapses out.
Mm,
Then, under the right conditions, if you're twisting, which you almost always are in those positions, what happens is the tibia not only comes forward, but it internally rotates. And together, boom, at the same time, within 30 to 50 milliseconds of ground contact, your ACL ruptures. So I'll give you the punchline of this talk in the very beginning, just so we can move backwards and forwards from there. Anything you can do to reduce the risk of this trunk movement, this valgus or tibial abduction movement, anterior translation or internal translation of the tibia relative to the femur, you're going to reduce the risk of an ACL tear. So I just want to say this too. This is controversial.
mm,
In order to reduce the risk, it needs to be mechanism based. And it also needs to be rigorous. It needs to be hard work.
mhm.
You have to change the neuromuscular profile. And I've followed you and your program. I regularly follow you closely, and you've brought up the whole issue of these warm-ups and how efficacious they are. These warm-up programs that are not rigorous,
Mhm.
like the FIFA 11, which was demonstrated not to work most people don't know that. That was in the literature, didn't work. So they added a couple exercises and called it the FIFA 11 Plus. They showed that that worked. However, when the new leadership of FIFA came in, there was a lot of accusations that there was academic fraud and misleading reports. And basically, as you've probably seen, that's why it's wiped off the FIFA website. So all of these quick fix warm-ups are based off fallacy. So I think that's really important to think about. And our work, which we did all through the 90s, was actually, we were bashed for being, number one, people didn't like the idea that we said there was differences between men and women. That was, especially at that time, highly politically incorrect. Just as what I'm saying right now is. I don't mind being politically incorrect. I'm about truth. So the truth was there were differences in men and women, and actually our data was used in Supreme Court cases that actually challenged Title IX, which we didn't want to do. That wasn't our purpose to challenge Title IX. The purpose was to make a difference, to look at the research, do rigorous mechanism-based studies, and figure out how these injuries occurred, why they occurred more often in girls and women than boys and men, and what we could do to reduce the relative risk of these injuries in girls and women, and also any athletes at relatively high risk of an ACL injury, like, for example, an NFL running back. So we were supported for decades in this work by NFL charities. Because of that, what we said is a female athlete is a high risk for ACL athlete. So is an NFL athlete. Let's try to figure out what they have in common. So going back to that mechanism, this mechanism here, rupture, what we said was, why do high risk athletes allow that to happen more often? The good news is, well, let's give the bad news first. The bad news is there are anatomic differences that funnel into this. We've published multiple meta-analyses on hormonal differences, also politically incorrect to say a woman's cycle can actually affect their biomechanics or their injury risk. It's known that it does. That's clear. The problem is when the injuries clump tend to be right at menses, but when estrogen is surging tends to be at the opposite end of the cycle, day 14.
Hmm.
So how does that all work? We can't figure that out, and we don't want coaches to try to figure that out because they can't. Yes, there's input there, but it's not something that you want to play around with.
Hmm.
The good news is that this injury mechanism is related to what we found over the next couple decades, which are neuromuscular imbalances in athletes that have high risk that relate directly to that ACL injury mechanism. So the first part of the mechanism, when I talk about the trunk or the center of mass moving around, especially laterally to the involved planted limb,
Yeah.
that's related to what we call trunk dominance, which is basically a lack of core control, a decreased core control when you're on a single foot base. It's basically what trunk dominance is. The other parts of the mechanism. So this valgus part of the tibia moving around relates to what we call ligament dominance. So that's the second neuromuscular imbalance. And what that means is people at high risk for an ACL injury, instead of using the big muscular movers, their core, their glutes, their hip complex, their hammies, their psoas, their gastroc, instead of using those big primary sagittal plane flexion extension movers to absorb and dissipate the ground reaction force when they hit the ground from a cut or a rebound, they allow that force to go directly to the knee joint and to hit the ligament. And to use a ligament to dissipate force is not a good idea because if the force is too high, it's going to rupture the ligament. Whereas the muscles, especially the big primary movers, the quad, the hammy, the calf complex, the hip complex, they're designed to absorb and dissipate force. Ligaments are not. Ligaments are just supposed to limit motion between the bones. They're not designed to absorb and dissipate force. So a ligament dominant individual allows that force to go to the ligaments. The other problem is that the other imbalance is that athletes at high risk, female athletes relative to men, NFL athletes relative to Pee Wee football players, they tend to be quad dominant, big, strong, massive quads that are not balanced by the antagonist, which is primarily the hamstrings, but also the hip complex. And so a quad dominant athlete, when you contract your quad primarily when you're hitting the ground, it does bring the joint together. But the problem is when you compress the joint, the structure of the tibia and fibia, the tibia and the femur, because the femur is convex, the tibia is concave, they fit together, but the difference in configuration of the medial versus the lateral side is that the the tibial lateral plateau is more convex. It's more like putting a bubble against a bubble. And what happens is it moves, it allows internal rotation. So a quad dominant individual does two things: compresses the joint together, which causes internal rotation, but also the quadriceps, that big strong muscle, the way it works is it pulls the tibia forward
Hmm.
relative to the femur. So again, what you're doing is anterior translation, internal rotation. That contributes. That actually increases stress on the ACL. So quadriceps dominance is a problem. And then the final one is leg dominance. As you well know, even the greatest soccer players have a dominant foot. You have to make athletes as balanced on both feet as you possibly can, because imbalances side to side, significant, measurable imbalances, especially in strength and muscle recruitment patterns. For example, if one leg is very quad dominant and the other is not, that's a really good predictor for injury risk. So, those are the neuromuscular imbalances. What is the good news? They direct relatedly right to the mechanism, and they're modifiable. So all four of those neuromuscular imbalances I talk about can be modified with rigorous targeted neuromuscular training. So that's the key in all this. And that's the good news in all this. We can change that profile. And like I said, we can change it somewhere between 50 and 67%. You're not going to reduce the risk of every ACL injury in every athlete, but those modifiable adapted neuromuscular risk factors we've shown again and again and again in many studies can be altered, and that athlete can become safer out on the field.
Well, that is definitely good news. And I always try to tell my audience on this podcast, we need to do what we can control for female athletes. And you nailed it. It has to be that rigorous, we always say consistent training. And I'm glad you mentioned the FIFA 11 plus because I've been questioning it for a while now, and everyone thought I was crazy. But I just, first and foremost, I didn't see these movements taught well enough. It was still like everyone's knees were wobbling like a tree. The trunk dominance was happening where girls were landing and swaying left to right. And it's just a disaster. And I felt like some of these warm-ups was just to like check a box and to not truly get our female athletes resilient. And then eventually, like, coaches would quit doing it because girls didn't look forward to it. And it became this whole problem. So I just want to reiterate to everyone listening the importance of a rigorous, consistent program. Can you maybe go into more into depth on what rigorous means to truly fix these modifiable mechanisms?
Hey guys, just want to take a quick moment to shout out our sponsor, Simply Faster, and one of my favorite speed timing systems from them, the Freelap. I use it for my own sprint training as well as for my athletes, and they love it. It's super easy to set up, you can take it to the field on your own, and you can get accurate speed times to track your progress. Check the Freelap link in the caption below to start adding timing into your speed sessions. If you know me, you know I love my Freelap. If you're serious about speed, it's time to start timing.
So first of all, you brought up two issues: compliance, which I relate to the coaches, and adherence, which I relate to the athletes. Coaches, they do want to, not everyone, but there are many coaches out there who do want to check a box. Let's make this all I want to do is skill training, which, by the way, a lot of skill training makes an athlete more neuromuscularly imbalanced. If
Yeah.
you're, for example, if you're teaching yourself, just one example, to kick a ball as far as you can kick, what are you doing? You're making yourself quad dominant. Now, why is that? Because you're exclusively training your knee extension, your quadriceps muscle, and you're training the back side of your thigh, your hammies, to turn off. Why is that? Because to maximize the power in the kick of the quadriceps, you need to turn off and it's called an antagonist for a reason. It antagonizes that extension movement of the quadriceps. So if all you're doing is teaching an athlete to kick a ball as far as they can, you're making them quadriceps dominant. You're creating quadriceps imbalance. That's why this training is, and I'm not against, obviously, you have to have skill training. That's to win the game. You have to do that. But you also have to have neuromuscular training that battles those imbalances. That's another reason why NFL players and NBA players are some of the most high risk athletes in the world, because they're so highly skill trained that they're creating neuromuscular imbalances in their bodies that put their bodies and their joints at risk of injury. So let's go back to the ideas of compliance and adherence. What you said was Coaches just want to check a box. I mean, it's understandable. Especially youth coaches are some of the most, along with athletic trainers, are some of the most overworked, underpaid, underappreciated people on the planet. They, of course, they want their kids to be safe, but their primary goal is to win, is to, you know, do skill training. That's why people like you are so important because we need coaches like you to do the background work, the neuromuscular training work, the strength work that's going to make them not only just better athletes, for sure it does, and all of our data demonstrates that as well. In 6 to 8 weeks of our training, we can improve vertical jump 10% in young girls. So performance is an important part of it, but the performance has to come with the injury risk reduction. And that comes with bringing more balance to those four neuromuscular imbalances that I talked about: trunk dominance, ligament dominance, leg dominance, quad dominance. Again, we've shown this over relatively short periods, 6 to 8 weeks, you can reduce that risk. The coaches, the athletes, if you present a good program to them, we have lots and lots of evidence that 2/3 of those athletes will follow that program. They will be adherent to that program. That's great. The problem is compliance, especially season to season, year to year. Coaching compliance is much, much lower than athlete adherence. Coaching compliance often is under a third. So if you present it to the athletes, they'll do it, but many coaches don't have time, energy, impetus to do the training itself. And then even if they do it and it works, they say, "Oh, look, I had less ACL injuries this year. It's not a problem." And there's clear data that shows you drop that off and you don't make it consistent anymore, boom, the injuries go right back up again. So the training needs to be rigorous enough to be demonstrated to alter those four neuromuscular imbalances that we talked about. And you can do that. You can demonstrate it along with measuring performance. There's lots of ways available on the market now, whether it be with portable force plates or cell phones or on IMU, inertial measurement units that you can wear on the body. You can, and we've demonstrated this in many different ways with full 3D biomechanics to onboard IMU systems. You can alter those profiles and you can decrease those neuromuscular imbalances. But you have to do so, you have to do it to that level, and then you have to do it consistently, season after season, year after year, to reduce the risk of these injuries from occurring. So rigor, consistency with targeted neuromuscular training that directly addresses those neuromuscular imbalances that feed directly into that injury mechanism. And I can't say that enough. This training, unlike these FIFA programs, PEP and others, it needs to be directly related to the injury mechanism.
Yeah, I love that. And I want to dive more into what you mean by neuromuscular because I'm sure a lot of people are like, well, what do we do? Neuromuscular or strength training? But I would say both ideally. But is neuromuscular more working on those movement patterns, being able to land on one leg in different planes, control your trunk in just a basic plank, like those types of movements?
What I mean is by neuromuscular, it needs to be more than simple strength training. It needs to be strength training that is ground based, foot based, field based, court based.
Mhm.
That's what I mean by that. It's not simple getting on a Nautilus machine or any, even free weights. That's good and that's part of it. Strength is important. You need to have strong enough muscles. Most of the time, strength itself is not the key problem or the key, or lack of strength is not the key problem. lack of muscular activation. Rarely, even in high level soccer match, you're only activating, say, your glute muscles, your biggest primary mover of your body altogether, but more importantly, the proximal head of your femur and your hip, which means it also controls the distal end of the femur, which means it controls the knee joint. You're only activating your glute max during any match, maybe to 50%, somewhere in that range. You're never, titanically stimulating that quad to max. So usually you have enough power in the muscle there, but it's the activation of that muscle at the right times during those events when this is occurring to counter it. And that's the absolute key to that. That's what I mean by neuromuscular. It's strengthening, but it is activating the musculature via the neuromotor system during chaotic events that apply directly to the court and to the field.
Now, what would be your recommendation as far as frequency? So, for all the sports parents listening who they maybe do like a strength program for a month, what would you say to that? And what is the best frequency?
I can say the data will show minimal 3 days a week for at least 6 to 8 weeks minimum. That's but in order to maintain, so say in the off on season, in order to maintain, you need to do at least 2 days a week. So at least 2 days a week on season, 3 to 4 days a week off season. Obviously, you want rest is important, is highly important as well, but 3 to 4 days, it doesn't have to be our training programs lasted normally 45 minutes, an hour max, no more than that. Now we actually, by the proponents of these people that came much later, they came a decade later, and I was actually involved in the development of all those programs, and they kind of shushed me and kind of dropped me out of there because I said you have to have these minimums, and they said no, 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 coaches won't do that. So we have to do these 5 or 10 minute warm up things because that's the only thing they're going to do. Well, they were wrong. And I think 30 years later, we know they were wrong. So, 45 minutes to an hour max, 3 to 4 days a week in the off season, and 2 times a week during in season. And you can cut down the intensity, obviously, in season. But consistency, off season, in season, you have to use those strength and neuromotor control mesocycles that are taught in all the strength training books that you well know that you have to cycle on and off, but you never just stop.
Mhm.
Consistency is absolutely key.
Yeah, it's so key. And I think that's one of the biggest misses in the youth female athlete community is they're just so busy with sports year round that their parents think continuing in-season strength training is overdoing it. But like you said, it can just be 45 minutes and it shouldn't cause fatigue. It should be programmed properly, and not too high volume that it makes them sore. So for the parents listening, please find a professional in your area who understands in-season training because it's not overdoing it if you have the right person.
And that fatigue point is absolutely key. Do not train these kids into fatigue. That is, for one thing, because it's neuromuscular, you want as near perfect technique as possible, especially with plyometrics or any kind of strength training. Technique, technique, technique. People talk a lot about fatigue. Fatigue is, if you look at it, and we've done a lot of meta-analysis on here, early on, a lot of the athletic training community wants to promote this idea that fatigue causes ACL injuries. It's not true. It's not true at all. Fatigue, if you look at the data, ACL injuries actually occur early in matches when people are fresh. Oh, you'd say, why would that be? Well, force is equal to mass times acceleration. And when you're fresh, you're accelerating more. So the forces are higher that you're hitting with, and that data is clear. So don't train athletes into fatigue thinking, oh, I've got to be, you know, protecting them in a fatigued situation. No, no, no. You don't want to do that at all. You don't need to train these athletes into fatigue. Near perfect technique is key, and you don't get that. You can't get that when an athlete's fatigued.
Yeah, and you can't get that if you're not being consistent either. The motor learning takes so much time. And I even just look back to when I have a novice coming in and I'm teaching them jumping and landing for the first time. It's not going to be perfect on week one, not week two either. It takes a few weeks under their belt to really get that patterning down, which is again why that consistency is so key. Because something like jumping and landing on one leg is very hard for girls, especially if they have that knee valgus and that trunk swaying, and we have a lot to correct.
I always tell this anecdote. My office used to be right off the laboratory at Cincinnati Children's Hospital, where I started the biodynamics lab there. And we would bring in entire teams of young youth female basketball and soccer teams. And we'd bring our athletic trainers would bring the kids in, and I'd be working on a grant to fund this work with NFL charities or the NIH. And it literally, they would bring them in to do just basic like wall jump plyometrics, and it sounded like cattle. And I would come out, big, mean. I'm about 250 pounds, bald guy, come out there and yell, ladies, quiet it down. And immediately they would do the wall jump to the same level, and it would go quiet. It was much, much quieter. That's how important just cues and coaching is. Because what were they doing? Well, when they got this cue of be quiet, what they did is they flexed their hips and their knee more, and they rolled their foot more, and they landed softer. And our data showed that too. Just by saying land softly, or using your ears, land quietly, you could reduce the ground reaction force by 40, 50%. So that's important too. But you're right. It takes time. It takes time to do that. You can do that one off for one set of wall jumps, but then you go into higher level plyos. It takes practice and repetition, repetition, repetition for them in all those situations to flex their hip, flex their knee, roll their foot, and absorb those ground reaction forces with those big primary lower extremity and core muscle movers to reduce just the sound of that. But sound is a great cue. It's not just video. Sound is a great cue for people too. If you're hitting the ground hard and slapping your foot on landing, that is a high force, high risk landing.
Now, I want to shift gears to ACL rehab. It seems that the re-tear rate is pretty high. I don't,
Ridiculously high. Let me tell you how
is it
high.
an epidemic worse than the first tear?
Well, I don't know if you can call it an epidemic because epidemics actually catch, from one person to another, but uh, it is a huge problem. So we've demonstrated this. We were back in 2010, we first reported this, where we showed that if you were a young athlete going back to the same level of sport, your risk in the first year was about a quarter of having an ACL injury, and your risk in 2 years was about a third. And
Wow.
that's ridiculously high. At the time we were doing these studies at my lab at Cincinnati Children's Hospital, I had 6 people in the lab who had two ACL reconstructions, either bilateral or a same knee, because that first ACL rupture is devastating. The second one is mind altering. If that happens to you and you want to make sure it never happens to you again or to anybody else, and that's you want to do research into and figure out how to reduce the risk of this. And we did a study after that when I was at Mayo Clinic where we showed in American Journal of Sports Medicine, we showed that where most of all of these papers I'm talking about are published. We showed that if you were a young female soccer player going back to the same level of sport, your risk of a second tear was 34%. I mean, and when we first reported this, people were saying you're nuts because a lot of surgeons who pride themselves on, especially their graft holding up, they don't like that data. There were surgeons out there saying the risk of a graft tear was 1 or 2%. I won't name any names, but I've had some massive battles
I'm
on
sure.
saying, "Oh yeah, Hewett, you're so wrong. I'm only 2% or 1% of my patients tear." There's a favorite of mine. I just call him Wild Bill. He's one of my favorites. Wild Bill claimed a 1% graft tear rate. In young females, it's more often the contralateral side that tears, so that doesn't bruise the ego of the surgeon quite as much. But in some ways, it's even more devastating to the young athlete because they're like, man, now I don't have any good knees left,
Mhm.
and it's just absolutely devastating. And when we reported this back in 2010, we were the first, and everybody said, "You're nuts. That can't be right." I said, you know what I told him? I said, it's because you don't follow up your athletes like we do. We're rigorous. Again, like I said, we're looking for that denominator. So we actually not only had the numerator, which is how many got re-injured, but we had the denominator, how much exposure they actually had. I mean, we had researchers tracking them, calling on them on the phone every week, every month. Have you had an injury? So we knew where these surgeons say, no, no, this is not happening. And then down in Australia, Kate Webster and Julian Feller, who, so Aussie rules football is crazy. So you're doing these massive speckies, catching the ball high in the air, getting your trunk perturbed either by yourself or a player, landing on one limb and popping your ACL. It's the highest risk ACL sport in the world. And they do huge. Julian, I think himself does several hundred plus ACL reconstructions. He's like the surgeon to the Aussie Rules Football League. They publish, and the thing I love about Kate and Julian is they're extremely honest with their data. It is, as humbling as it can be to a big surgery group like that sees 600 plus ACL injuries and reconstructions a year. And they very forthrightly published the exact same numbers we did. A third. And if they track over time, they show your risk of a third ACL injury is another third, and a fourth ACL injury is another third. It's massive. And it's exactly, they published exactly the same numbers we did. Risk somewhere between a quarter and a third. And then Leo Pincheski in Sydney, Australia, another huge volume guy, published exactly the same numbers. And that's consilience and data. That's what a scientist loves, right? When all the data comes together, shows you exactly the same numbers. You can say we're wrong, but it's not us that's wrong. So this is a massive problem. And since the last 15 years, since 2010, since we first discovered this is what I've been focused on. It's a huge problem. I will say this in it. So the best predictor of future injury is prior injury by far, better than anything. So someone who's at an ACL already is the highest risk population there is. So if we can reduce the risk of primary injury by somewhere between two-thirds and a half, This is the hypothesis I've been testing for the last 15 years, and I still haven't figured it out yet. I don't think you can reduce the risk of a second tear by that much because you've got a very, very high risk population. I think you can probably reduce it by half of that amount, which is somewhere between a third and a quarter. So, which is going to be impactful, right? It's going to decrease about half of those injuries that occur. So that's important. But man, again, young female soccer player going back to the same level of sport, 34% in the United States. And this was a massive study. We used the Mayo Clinic Rochester Epidemiology Project, which goes back to the 60s, NIH funded since the 60s. Massive numbers, tens of thousands of patients, 34% risk. That is crazy and it's completely unacceptable. And if I die trying, I'm going to try to figure this out and try to do what we can to reduce that risk.
These are some crazy stats and findings. It makes me cry. I mean, I work with girls who are in the return to sport from ACL injuries, and when you see what the girl goes through, the parents, and just how devastating it is for everyone involved, it makes me cry every day.
It's terrible. It
It's
is
and then
devastating.
that second one, it's like we want to do what we can to reduce this at all costs. And I think like rehab can be better in most cases, but it's
It needs
just
to be
so,
more targeted, and again,
yeah,
it needs to be, and we've proven this too. It needs to be directly. We've done these studies in second ACL injuries, same as primary. It needs to relate directly to that ACL injury mechanism, and it needs to relate directly to those four neuromuscular imbalances because you, in some senses, you've got an easier population to work with because you know their risk is super high, and you know that they're going to demonstrate those four neuromuscular imbalances that I talked about of trunk dominance, ligament dominance, quadricep dominance, and leg dominance. You know they have those dominance patterns. They are the predictors of not only first, they're even better predictors. We could predict with over 90% accuracy risk of a second ACL injury based on those four neuromotor imbalances that we could discern in that population. So the rehab has to be directly targeted to those neuromuscular imbalances that that specific athlete demonstrates. And it needs to be mechanism based, directly relate to the ACL mechanism because that mechanism is the same, whether it's a first or a secondary injury, and it needs to be targeted to those neuromotor imbalances that that athlete specifically demonstrates. And you can do that, but
yeah,
that's not done very often. Maybe
it's
at the
not.
highest, maybe at the highest levels, maybe it's some of the pro levels, but down at the college and especially at the high school or even junior high school level, it's not done, and it has to be done.
I can tell you it's not being done. Just being in this and seeing girls come to me several months post-op, and I'll have them do just a tiny, like a 2-inch step down off of a box, and their knee is caving in, it's wobbling
Even
every which way, they're collapsing their trunk forward, they're swaying, and I'm like, what have you been doing for the past 6 months here?
no core control, no hip
None.
control.
And it's been,
Their quad, which is an important, very important muscle, is shrunken from arthrogenic muscle inhibition. I
yes.
mean, yeah, they're yeah, over that time, and people don't realize too, surgery is also extremely traumatic to the neuromotor system. So there's not only the injury, there's the surgery, and then the rehab, if not done properly, can also be even more traumatic. So there's a lot to deal with here. And people have to be cognizant of all of those issues, the issues related to the injury itself, what was there before pre-injury, what's after the injury, what's done between injury and surgery, the surgery itself and all the issues and what graft you might take. For example, in a young female athlete who's highly quadriceps dominant, don't do a hamstrings graft.
Yeah.
You're making a quadriceps dominant athlete almost solely quadriceps reliant. That's crazy.
Right.
Don't do that. So there's surgical issues here too. So all this down the line has to be addressed and individualized to every single patient. But again, that overall framework of those neuromuscular imbalances that show us that are present, that we can alter, that predict the risk of secondary primary injuries, that trunk dominance, ligament dominance, quadriceps dominance, leg dominance, they can be addressed. But figure out which one of those, usually it's going to be two or three, if not four, especially in an athlete returning from an ACL. You have to specifically address those in that specific athlete in an individualized, science based, mechanism based fashion.
Yeah. I love it. I think these are some actionable items for everyone to focus on. And again, I know I say it every episode, guys, but if you're not working with someone in your area, please sign up tomorrow. Like you need to be under the guidance of a professional and you need to be taught these movements properly and corrected. Too often I don't see these young girls being corrected enough on these mechanisms. So Tim, is there anything else you would end with today? I know we talked about a lot. It was
Just
really
just one
fun.
more factor, psychology.
Yeah.
Psychology is a huge factor. And just very quickly, any psychological parameter that I measure is going to have a U-shaped curve like this. It's going to be an inverted U, where we have to have those kids psychologically when they're returning to sport or when they go out to any sport, is we have to have them at the top of that inverted U. They have to be here because if that kid is down here, he's super confident, wants to get back to sport right away. He passes through every test that he's given and he gets back in 4 months and he goes out there and puts himself in a very high level exposure. He's at risk probably of a quarter of having a second ACL injury.
Oh,
Now you
wow.
go up the bell curve, the inverted U, you go to the top. Those people have a psychological profile. Use the ACL RSI tool that Julian Feller and Kate Webster developed.
Yep.
Keep them, you want them above, say, 76 out of 100 on that scale. That's going to put them right there. Now, down on this other side, the girl who's really fearful, she's got a lot of anxiety, she's worried about how her knee feels, and she's worried about having another ACL injury. She has a risk of about a third of having another ACL injury. You've got to address both, and you've got to get them into the top of that inverted U on that psychological profile. Use the ACL RSI. Kate and Julian have it out there for free. It's a great, easy tool. They even have a short form now, which I think is 6 questions. You can find it online. Use it. It's an awesome tool. Psychology is absolutely key here. And what you want to do is over time through rehab is make sure that they're stepping up. They're stepping up, up, up. What's worse, where their risk is going up, is if they're going down. So a lot of times they'll go like that young boy who's, oh, I'm so confident, I'm so fast, I'm coming back so quick. He'll be like this. And then he gets out on the field and he realizes, man, this knee isn't quite the same thing as it was before. Boom, and he comes down. So you want to make sure that you're longitudinally, as we said before, consistently rigorously testing and measuring all these parameters and giving them feedback to say, look, you've come down here a bit. Do we need to talk about this? What do we need to do to bring your confidence back in that knee to where it was before? So
Mhm.
these are key ingredients. Psychology plays a huge factor here. I can't stress that enough.
I think that's a piece that's also missed in the return to play process is not touching on that piece. And I really like the RSI form you're talking about. I'll link it below so everyone can take a look
Yeah,
at it. I
please.
use it as well for my athletes and it has been so valuable to see where everyone's at because it surprises you sometimes and you're like, okay, we might have to take a step back here and do some things to make sure you get to a good spot. But Tim, this was really great. I'm going to include all of your social media in the caption below, and I'll provide any publications Tim provides that
Yeah,
we
yeah. And a
reference in the
shameless
book.
plug for my book. I
Yep.
don't make a dime off this. It all goes to research at American Orthopedic Society for Sports Medicine. You can get it anywhere on Amazon, wherever.
Awesome.
So it's all there.
Okay, perfect. Yeah, I'll include that in the caption below. And guys, please take notes, listen to this again because there's so much good info in here, and Tim's one of the best in this space. So we hope you enjoyed the episode, and I will see you next time.